We are heading towards session 2 of today's scientific program. It is nephrocritical care. Critical care and nephrology. A match made in heaven or a mere crush. With the increase in serious kidney diseases, including end-stage renal disease, the role of critical care physician has become even more crucial. I hereby invite our chairpersons for this session, Dr. Ripal Patel. She is consultant intensivist at Ahmedabad. Dr. Rudra Parmar. He is consultant intensivist and pulmonologist at Ahmedabad. Dr. Minesh Patel, consultant intensivist and pulmonologist, CIMS Hospital, Ahmedabad. Dr. Bhagyesh Shah, consultant intensivist at Ahmedabad. We all are fortunate to have good, healthy body and mind. Just imagine the situation if our kidneys suddenly stop working. Acute kidney injury or acute renal failure is a condition where the kidneys suddenly stop working properly. The first speaker of this session is Dr. Bhagyesh Shah. He is senior consultant intensivist and course director ICU and ER at Marengo CIMS Hospital. His area of expertise is airway, trauma, infection, toxicology, obs-gynae, peri-op and palliative care. Welcome, sir.
Thank you, organizers and chairpersons. After your fluid responsiveness challenge, now we are seeing how the kidney is working. Kidney and critical care is something which has troubled us as intensivists, which has troubled our team practices when we are dealing with our nephrologist, and it has caused many confusions while treating the patient, whether to give fluids, whether to give diuretics, and whether to go for dialysis. So my topic is limitation of creatinine and urine output in AKI diagnosis and what are the newer renal biomarkers. So we'll start with what is a biomarker. A characteristic that is objectively measured and evaluated as an indicator for a normal biological response or a pathogenic process or even a pharmacological response to a intervention. So ideal biomarker is like choosing your ideal life partner. It's never going to get completed. So if you go by the science of ideal biomarker, there are many, like it should be non-invasive, easily measured, inexpensive, and producing rapid results. Readily available source like blood or urine should guide us. It should be highly specific, highly sensitive, should have minimal variability, and should be immediately changing as the severity or the progression of the disease happen. Coming to a case where we would like to discuss how the biomarkers have gained space into our practice of nephrology and critical care. A 57-year-old diabetic hypertensive male with intestinal obstruction presented with abdominal distension since 4 days and fever. So probably abdominal sepsis was there. His creatinine increased to 2.4 after first CECT abdomen was done to diagnose this intestinal obstruction with ongoing shock. With adequate fluid resuscitation and optimizing hemodynamics, urine output also improved and the serum creatinine is 1.6. Now the patient on day 8 of surgery is requiring a CT pulmonary angio to rule out a pulmonary thromboembolism, and there are acutely worsening hemodynamics. The cardiologist has suggested that you have to go for CTPA. So this is a common scenario in our ICU. All of you must have faced such scenario, and the question would be, how bad are the kidneys right now? Are they recovering? Are they recovered? Or are they totally dumb where they will end up in dialysis? So such scenarios happen day in, day out in our practices, and these are the places where a biomarker can help. That is what we are going to discuss further in this session. So what did our KDIGO guidelines came up with? Criteria based on urine output and creatinine, and they said that there are some preventive recommendations. So what are the preventive recommendations for avoiding AKI in your ICU? Withdraw nephrotoxic drugs, ensure euvolemia, renal perfusion pressure by means of advanced hemodynamic monitoring and management, monitor plasma creatinine and urinary expenditure, avoid hyperglycemia, and consider alternative for diagnostic and therapeutic radio contrast procedures. So we all are following this day in, day out, but still there is some issue which has not been solved, whether to judge for our case that this kidney will fail to require dialysis or this kidney will sustain that radio contrast exposure second time. Fusemide stress test, everyone knows and everyone loves it. So whenever we are in doubt, we give a bolus dose of diuretics. But that has not cleared as a therapeutic tool, or that has not cleared any validity by saying that in this patient this will work and in this patient it will not work. So again, it is not a parameter to judge or tell that my kidneys are recovering or my kidneys are failing. So what are the limitations of serum creatinine, which is used by the KDIGO guidelines? And remember, KDIGO guidelines came in 2011-12. So we are already 10 years past. So serum creatinine level, as we know, is influenced by multiple factors extrinsic to kidney like age, sex, muscle mass, metabolism, diet, medication, amputation, and hydration status. Again, it is reflective of glomerular filtration rate, that is your GFR. It doesn't clearly identify the tubular injuries, and it may not become elevated before the substantial kidney injury has occurred. It is not again reliability for assessing the kidney function in terms of prerenal azotemia or a uropathy or intrinsic renal failure. Decreased production in sepsis. We see at least 30-40% ICU admissions for sepsis, and there it is causing a caveat. So creatinine alone we know, or as a urine output plus creatinine measure in KDIGO guideline, still is not able to answer our question that my patient will require dialysis or not, or at which kind of kidney injury risk he is sitting at. So as you see in this diagram, normal kidney going to decrease GFR, where your creatinine and urine output will start changing. This phase is something where biomarkers can help, and over the time the research has shown there are biomarkers which are seen for the reparatory phase also of the kidney injury. But we will concentrate on AKI, and here the biomarkers which we are going to discuss are endless. So I will try to discuss only biomarkers which are either available or which are more validated or more studied. So again, going for the ideal nature of the biomarker, changing rapidly and reliably in response to kidney disease, sensitive and specific, highly enough for AKI or whatever kidney disease you want to diagnose. There are biomarkers for CKD, there are biomarkers for reparative process of AKI also. Providing risk stratification and prognostic information, how to manage and how to stop your kidney toxic drugs, that also information should be provided by our biomarker. It should be site specific, where we can actually ascertain that what is the pathological process happening, and it should be relevant among different species and races. Okay. Endless biomarkers have come over the years. Just to name a few in this slide, I have added few. NGAL, neutrophil gelatinase associated lipocalin, interleukin 18, kidney injury molecule 1, KIM1, liver type fatty acid binding protein, that LAFBB, insulin-like growth factor binding protein 7 and TIMP2, that is tissue inhibitor of metalloproteinase 2. These are different biomarkers. We'll go one by one into detail of one of these or some of these, but remember that the list is more than 3-4 slides. So we will discuss only which are more validated or more studied. It's like choosing one of the Avenger. You will all have different choices and still you want to defeat Thanos. So biomarkers for tubular health. As you can see, for proximal tubular injury, NGAL, KIM1, TIM2, IGFBP7. For function, cystatin C, we all know that, alpha-1 microglobulin, and LFBB. For distal tubule, NGAL is specific. For inflammatory markers, IL-18, IL-6, IL-10, TNFR1, TNFR2. And for loop of Henle injury, uromodulin. So there are different sites where these biomarkers are secreted in response to acute kidney injury. And this is another diagram where it is biomarker of inflammation being released, then tubular function, LFBB, cystatin C and alpha-1 microglobulin, and NGAL as a tubular injury. So coming to individual biomarkers, I will speak on certain biomarkers, specifically how they are important or how they are being used or being studied. So starting with NGAL, neutrophil gelatinase associated lipoprotein. That is basically plasma and urine, both samples are measurable. Indicates distal tubular injury particularly, rises in 2 hours of injury, and it is very well studied in post-cardiac surgical and sepsis cases. So this is a bunch where we see lot of patients in our ICU. So increased NGAL expression happens in ischemic, septic or post-transplantation acute kidney injury. As an early biomarker of AKI in pediatric patient undergoing cardiopulmonary bypass surgery, it has been studied and then it was introduced for adult cases also. STEMI patient undergoing percutaneous coronary intervention, also there is a study which has shown importance of identifying AKI before the creatinine or urine output drops. Decompensated cirrhosis, again it helps in identifying or managing your hepatorenal syndrome. So the functional utility of NGAL as a biomarker of AKI has been evaluated in these 3 contexts. One is early prediction in cases of sepsis, post-cardiac surgery or drug toxicity. Other is differentiation of underlying pathophysiology, as I have said, cardiorenal syndrome or hepatorenal syndrome, and prediction of progression of the disease. Interleukin 18 is inflammatory biomarker, which is a cytokine released during acute tubular injury, and along with IL-6 it can be used as inflammatory marker, but again it has not been very well validated and it is released in many other diseases also. Kidney injury molecule 1, which is again a biomarker for proximal tubular injury in cases of proteinuria, ischemic or toxic injuries. It is also elevated in certain drug toxicity. So if you want to study a drug for toxicity in clinical research also, they are using KIM1 as a biomarker to identify for kidney injury, and it is marker for repair also. Liver type fatty acid binding protein, which is marker for acute ischemic injury and expressed by proximal tubules, as we have seen in the previous diagram. Coming to this urine insulin-like growth factor binding protein 7, that is IGFBP7, and TIM2, tissue inhibitor metalloproteinase. These are the enzymes which are released in cell death cycle. So when there is an injury to the tubules and the cells are dying, these are the markers which are released. So they are basically a mediator of cell cycle arrest, expressed in response to injury and discovered in the background of critical care settings. So initial studies were done in critical care patients, and it is the only thing which is approved by FDA. The kit approved is called NephroCheck. I don't know if it is available in India or not. Only NGAL, as far as I know, is available. uromodulin or TEM Halswolf protein, that is marker of remaining functioning tubules. Most of the markers we have seen is showing tubular injury. This says that how much tubular functions are remaining, and the more the number, the good is the function. So urinary uromodulin level, if it is higher, it is good for your kidney. Microalbumin, again it has been used as biomarker. Enhanced secretion has also been linked to vigorous exercise or urinary tract infection, hematuria and dehydration. So it is not very sensitive alone for the kidney injury. Cystatin C has been studied a lot, but again it is non-specific, just like your creatinine. There are biomarkers for nephrotoxicity also. So when we speak of nephrotoxicity, it is basically two ways. One, nephrotoxicity due to your therapeutic drugs, and nephrotoxicity assessed in clinical research of newer molecules. So certain biomarkers to name are N-acetyl glucosamidase, glutathione S transferase, gamma glutamyl transpeptidase, alanine aminopeptidase, LDH, and KIM1. NAG or N-acetyl glucosamidase is an enzyme predominantly found in the lysosomes of the proximal tubular cells, again used as a nephrotoxicity marker for drugs like cisplatin or lithium or our aminoglycosides. GST or glutathione is again used as a biomarker for polymyxin or the colistin induced toxicity. GGT, AAP and LDH. LDH was the most sensitive marker for AKI among these three, but it is non-specific, so it is not used as a prime biomarker in most of the studies. It has been shown to show kidney injury, but it is not very sensitive and specific for acute kidney injury. Coming to KIM1, again as we have previously discussed, it is also a marker for nephrotoxicity to certain chemicals or drugs, and it has been quite more studied than other nephrotoxicity markers. So there is one subset which again is a major subset in our ICU practice, that is diabetic nephropathy patient. There can be multiple mechanisms where the tissue injury happens. It can be tubular injury, it can be chronic inflammatory injury, and it can be a maladaptive repair. So here you may have a confusing result with a single biomarker. So diabetic nephropathy is a caveat where we are using biomarkers alone may show some issues while managing the patient. Coming to how do we use these biomarkers? So for example, if you have a post-cardiac surgery case, you have a biomarker like NGAL and IL-18 which are elevated. It will say that there is subclinical kidney injury and you can prevent the kidney injury from further progressing. In cardiorenal syndrome, if there are low injury biomarker levels are there, then there is absence of true intrinsic injury. So it is the fluid management from outside which you want to manage. Okay. So despite increase in serum creatinine, you can continue diuretics as mainstay of treatment to optimize your decongestion. For hepatorenal syndrome, again low biomarker says there is no intrinsic absolute injury happening to the kidneys, and your treatment with vasodilator to prevent progression of likely hepatorenal syndrome should continue. For kidney transplantation, again higher level of biomarkers will say there is high reparative potential. So that kind of help from biomarker you can get from your ICU subset of patient with post-cardiac surgery, cardiorenal syndrome, hepatorenal, or even kidney transplantation. We are seeing a lot of transplantation happening in Gujarat, Ahmedabad and other cities also. So where we stand with our biomarker use is for septic AKI, hypovolemia, post-surgery, acute on chronic, heart failure related, hepatorenal, nephrotoxicity of drugs, trauma, obstruction, rhabdomyolysis or inflammation. All this kind of patient, somewhere here where the biomarkers are going to help us before the kidney function in terms of creatinine and urine output change, we can prevent the kidney injury from further progression. And how do we use it further? Obviously, cost is the issue, but as far as our ICU costs are increasing, the cost may not be the permanent issue. Once more players are coming, the cost will go down. This is a simple flowchart how we will manage this. If your biomarker is positive and your serum creatinine and urine output both are static, not much change, you will start acting here. This is the phase you can act actively to allow this not to progress to further AKI worsening. If your biomarkers are positive and your creatinine and urine output according to your KDIGO guideline have already worsened, you are already into the worsened kidney function. Again, going back from your resuscitation and other strategies of kidney function management, you will see the biomarkers coming down. Where your creatinine and urine output may have still been altered, but your biomarkers are coming down, that is a sign that your kidneys are improving. And at the last, when your biomarkers are negative and your creatinine and urine function are also returning to normal, you can say that patient has been surviving out of that acute kidney injury. So for my patient who I discussed initially, I will use one of the biomarkers and check which stage I am staying right now. If I am staying at here, I will be cautious. If I am staying at here, I will be easy to go. But again, as I have said, the creatinine was 1.6. So I am somewhere here, so I will be cautious for using contrast. And if patient is rapidly worsening, hemodynamics are not allowing for me to go even for that CT scan, I would use supportive tools here, my echocardiography and bedside Doppler to decide for thrombolysis rather than going for CTPA to confirm a thrombus. Thank you.